Hello, everyone. Can I just check that you can hear me?
Yeah, we can hear you. Right?
Fantastic, fantastic. Right, so thank you for joining us for the 4th MEDx event, Narrowing the Gap, Healthcare Digitalised. I'm Rachel, I'm a 4th year medic, and I'll be one of your hosts this evening, along with Lohith, a 1st year engineer. So Lohith, give us a wave. So first of all, a little bit about the Cambridge MedTech Foundation. So we're part of the National MedTech Foundation, and we're one of many spokes across the country. We're a student-run society at Cambridge and have been since 2018. We strive to educate, inspire, and connect the next generation of healthcare innovators. To do this, we run 2 projects, the Innovation Programme and MEDx Talks. So the Innovation Programme is run on a yearly basis. It's a long-term program that strives to help its participants understand medical device development. I took part in the program last year, and I'd really encourage anyone who thinks they might be interested to apply for next year. MEDx is a series of talks where the conversation focuses on different aspects of medical technology. Since this industry relies on interdisciplinary collaboration, we also aim to help you network and meet each other. We have a fantastic lineup of speakers that we're really thankful to hear from today. Following each of their talks, we will have an opportunity to ask questions. So if you could send them in the main chat or to Lohith or I, we'll read them out. This will be the order of events for today. So we'll have 3 talks with networking in between, and then an event called Soapbox at the end. So I'd like to introduce our first speaker, Dr. Pearse Keane. So Pearse is a consultant ophthalmologist at Moorfields Eye Hospital in London and an associate professor at the UCL Institute of Ophthalmology. He graduated from University College Dublin in 2002, and he's responsible for initiating a collaboration with Google's DeepMind to develop AI algorithms with the intention of detecting retinal disease earlier. Results of this collaboration have been published in Nature Medicine in both 2018 and 2020. He's achieved several accolades. So he was featured in the Evening Standard Progress 1000 in the list of the most influential Londoners. In June last year, he was profiled in The Economist. And also in 2020, he was listed in the top 100 of the Ophthalmologist magazine. So with that, I'd like to introduce Pearse Keane, and I'll let him tell you about his achievements in the field of AI and ophthalmology.
Rachel, let me first thank you for that very kind introduction. And actually, Rachel, thank you more broadly for inviting me to give this lecture today. I'm really looking forward to it. I'm just going to share my screen. And hopefully this will work. So over the next 15 minutes, I'm going to tell you a little bit about the potential of artificial intelligence to transform healthcare. And I think that there's a lot of hype around AI in healthcare, but at the same time, I do think it has a transformative potential. And one of the things that I believe, and perhaps I'm very biased here, but I believe that ophthalmology is one of the medical specialties that is at the forefront of this transformation. And in fact, can be an exemplar for other medical specialties in terms of AI-enabled healthcare. Now, in the bottom right of the screen, I have taken the liberty of giving my Twitter handle, because I'm always looking for more followers on Twitter in case anybody's interested. But in any event, let's get going. So just to tell you a little bit more about my background. So I'm a consultant ophthalmologist at Moorfields Eye Hospital in London. And at Moorfields, I specialize in the treatment of retinal diseases. So I specialize in the treatment of diseases such as AMD, which is age-related macular degeneration, which is the commonest cause of blindness in the UK by far. And I also specialize in treatment of diseases such as diabetic eye disease, which is the commonest cause of blindness in working age populations in many countries and many regions around the world. Now, I'm very fortunate in that I have a joint appointment, so I'm a clinical academic, and I'm also an associate professor at the Institute of Ophthalmology at University College London. And so at UCL, I lead a multidisciplinary clinical research group, which, as I say, is about which is focused on developing and applying AI in healthcare using ophthalmology as an exemplar. And then the other thing that I think is worth mentioning is my funders. So I'm funded by UK Research and Innovation as a Future Leaders Fellow. And so this gives me a very privileged position in that 80% of my time is protected for research and innovation. And I typically spend about 1 day per week in the clinic, which I think is the perfect kind of mixture for this type of work. And as an aside, if anybody attending here is interested in kind of clinical academic pathways and pursuing that type of career, it's something that I'm very happy for people to be in contact with me about, and I'll give my email address at the end. The other thing to say is that I have some financial disclosures. And so given the nature of the talk, I think it's important that I say that I've acted as an external consultant for the artificial intelligence company DeepMind. So if I start to get too excited or over enthusiastic over the next 10 or 15 minutes, please bear in mind that I do have that disclosure. Now, why do we need artificial intelligence in healthcare, and particularly in ophthalmology? Well, some members of other medical specialties, and I won't mention any names, but there's sometimes people think that other doctors think that ophthalmology is like a small specialty or a niche specialty or a little bit of a cushy number in some ways. But in fact, since 2017, ophthalmology has overtaken orthopedics as the #1 busiest of all the medical specialties in the NHS in terms of clinic appointments. And so in fact, nearly 10% of all clinic appointments on the NHS are for eyes, and that constitutes just under 10 million appointments per year. Now, the fact of the matter is that there are that represents huge logistical challenges, and that there are some patients who lose sight and sometimes even go blind because they can't be seen and treated in a timely enough fashion. And so one of the things that I believe is that new technology and innovation can play at least some role in beginning to address that. Now, in particular, I believe that artificial intelligence can play a central role in healthcare. And for the most part, when I'm talking about AI, I should be more specific, and I'm referring to a technology which is called deep learning. And since in 2015, Scientific American listed deep learning as one of their world-changing ideas of the year. And deep learning is a technique that has transformed the tech industry in some of the world's largest companies over the last 5 or 10 years. And in the last 2 or 3 years, we've started to see it being deployed in healthcare to a large extent, albeit still within the early stages. Now, in July 2016, I initiated a research collaboration agreement between Moorfields and the artificial intelligence company DeepMind. Now, I guess to an audience like this, most of you will be very familiar with DeepMind, but DeepMind are a company that were founded in 2012 in London, and 2 of the 3 co-founders are alumni of UCL, which of course is affiliated with Moorfields, and 2 of the 3 co-founders are from London. So they were founded in 2012 and they were acquired by Google in 2014, reputedly for about 400 million pounds. And they now employ about 1,000 people in their headquarters in the King's Cross area of London. So from my perspective, that was very auspicious, given that Moorfields is just 2 stops away from King's Cross on the tube. And so in about July 2015, I was reading a profile of DeepMind in Wired UK magazine. And I was reading an interview with Demis Hassabis, and I was reading part of the profile where there was an interview with Mustafa Suleiman, who is the co-founder and the head of the applied division of DeepMind. And in that, Mustafa said that they were interested in using their technologies in terms of making the world a better place, healthcare, climate change, energy consumption, etc. And so that was the light bulb moment for me. And so I thought, this is a person who is not too senior, not too junior, but maybe may know more fields and may be interested in collaboration. So I found his profile on LinkedIn. I took out a 1-month premium subscription so that I was able to send him a message without being connected. And I effectively said to him, I'm a consultant at Moorfields, and we're generating thousands of retinal scans per week at Moorfields. And there are some people who are losing sight because they can't be seen and treated quickly enough. Can we work together to develop a deep learning system? And by the way, we're 2 stops away from you on the tube. Now, to be more specific about the application in ophthalmology, it was to apply deep learning to the dominant imaging modality in ophthalmology, which is called an OCT scan. And OCT stands for optical coherence tomography. And OCT is a little bit like an ultrasound, but it measures the reflections of light waves rather than the echoes of sound waves. And of course, because light is so much faster than sound, it is able to do it with very, very high resolution. So the resolution of an OCT scan is about 5 micrometers. So it's an order of magnitude better resolution than an MRI scan or a CT scan. And even better, it takes seconds to do, and it's completely safe and easy to do. So whether you're a 5-year-old or whether you're a 95-year-old, we can do an OCT on you. Now, we initiated the collaboration or formalized the collaboration in 2016. And so it was, after much hard work, it was exciting to publish the first results of this in Nature Medicine, as Rachel said at the start, in August 2018. And so one of the things you can see here is that there's more than 30 different co-authors on this paper. And this reflects the fact that this was really a multidisciplinary research collaboration. Now, not only was it published in Nature Medicine, but it was tremendously exciting. It was featured on the cover of Nature Medicine. And then, given that this is AI and you can't escape the hype around it, it was also tremendously exciting that it got global media attention. Now, as someone who's written a lot of papers that I have been very proud of, and that probably less than 5 other people have actually read, other than my own research group, it's very nice to be able to for your research to get so much attention. On the other hand, I want to be really clear with the people listening. It's also a little bit awkward, because the fact of the matter is we have not saved the sight of millions of people yet. And in fact, in 2021, we have not even saved the sight of 1 single person yet. And in fact, we are not yet using this algorithm in real life for direct patient care at Moorfields. And so this is something I'll talk about in the second part of this talk, which is that there's a very big difference between just publishing a proof of concept in a research paper and going from code to clinic. So let me just show you the algorithm in action. This is a scan of a patient with type 2 diabetes in his 40s, poorly controlled. We feed the raw OCT scan in, you can see that at the bottom, and a segmentation network delineates about 10 or 15 different anatomic parameters on the scan. In this case, the patient has diabetic macular edema. On the second row, we can see a heat map generated from that intraretinal fluid. And then the top row, we have the outputs of a classification network. And this says semi-urgent referral, and it diagnoses macular retinal edema with 98.5% certainty. So where are we with this? Well, we're trying to bridge the AI chasm. And this is a term that we borrowed from the tech world. And it's the idea that it's one thing to do a cool demo of a machine learning model and raise some money. It's another thing to deploy it at scale. And of course, if it's hard in the tech world, it's probably an order of magnitude more difficult in a healthcare setting, which is so highly regulated. So what we've been working on since August and September 2018. So firstly is the technical maturity of the algorithm. And at Wired Health in March 2019, we did a live demo of a new version of the algorithm. And basically, the team at Google rewrote the system so that it was in the form of a cloud-based API that could produce results with a fraction of the computing power in a fraction of the time. And we did a live demo there. The other important thing is clinical validation. And so in our Nature Medicine paper, we did a large retrospective valuation, but that isn't really enough. In fact, we were involved separately in a paper in the Lancet Digital Health at the end of September 2019, which was a systematic review of deep learning papers in medical imaging. And the long story short is less than 0.5% of them were actually robust in their clinical validation. And so this is something that really needs to improve as the field matures. And so one of the things we're doing now is testing our algorithm on OCT scans from Africa, South America, North America, Asia, and trying to make sure that it works on patients globally. The other thing just to highlight is that once you've got your clinical validation, your technically mature algorithm, the biggest barriers are around regulatory approvals, such as FDA approval. And even when you get that, you have to figure out who's going to pay for it. In the UK, will NICE approve it? In the US, how much will Centers for Medicare and Medicaid Services provide for such a system? And even when you've got that, will doctors and healthcare professionals use it? Or will the institutions have the flexibility to use it? Now, at Moorfields, we're building a new hospital in beginning next year in the King's Cross area. And we're already trying to think about how we can have flexible pathways of care so that as AI as a field matures in healthcare, we can take advantage of what it offers us. And more broadly, I think one of our aims is how we can better link hospitals with community optometry settings, how we can have the appropriate telemedical infrastructure so that we can fulfill the promise of AI in ophthalmology, which is to see how we can bring world-leading expertise from the hospital into the community and maybe even into the homes. So I can't resist a little bit of self-promotion here at the end. This is regarding, if anybody wants to learn a little bit more, on February 17th this year, we'll have a course which is on February 17th, but of course it can be taken any time after that, which we've called An Introduction to AI for Clinicians. And essentially, this is about an 8-hour course, which will talk about everything that we've gone through over the last 5 years in developing this system. So we'll give an overview of the concepts of deep learning. We'll talk about how to identify use cases, how to aggregate and curate data. And that's not just the technical aspects, but the ethical and the governance aspects of that. How to work with computer scientists and engineers to develop models, how to do clinical validation, and then what's required for implementation of such systems. The other thing that we'll do that I haven't talked about at all here, but maybe I can tell the society about in the future, is that we're going to teach people how to do something called automated deep learning. And this is the idea that healthcare professionals without extensive coding expertise can now use these automated deep learning platforms to develop their own AI systems. And I think that's the future of AI-enabled healthcare. One thing to say, the course is a bit expensive, but there is a 20% student discount. So just to finish up then, I hope in this sort of just a few minutes or so, I've planted a seed of how there is the potential for artificial intelligence to transform ophthalmology, in particular to take technologies such as the slit lamp, which are more than 100 years old and little changed over that 100 years, and reinvent them for the 21st century. Now, if you'd like to learn a little bit more about that, myself and one of my heroes and mentors, Dr. Eric Topol, wrote an essay about this in The Lancet in December 2019. And then lastly, if anybody would like to get in touch with me for ask me questions or seek advice or anything else I can do to help you, that's my email address. Thank you very much.
Thank you very much, Pearse. That was a fascinating talk. And so if people could go sending your questions into the chat or to Lohith or myself, we'll be able to ask Pearse a couple of questions. Right, so one of the questions we've received is, How do you think that patients will feel about the use of AI in their diagnosis in the future, instead of perhaps seeing a doctor?
So I think that I guess it depends on how we use it, doesn't it? I think that let's see, how should I answer this? I think something that Eric Topol talks about is that AI can give doctors the gift of time. And this is the idea that it reduces all the kind of bureaucratic, administrative type of stuff that actually takes up 80% of our time, and allow us to focus just on, in my case, dealing with people with sight-threatening disease, and give us the gift of time to be able to interact with them and provide the care that is required for such patients. I think more broadly, I think that there'll clearly be some parts of the clinical pathway that can be replaced, can be automated, that don't need for you to wait for months to see a doctor, or wait in a waiting room for 2 hours for like a 2-minute consultation. On the other hand, I think that there are some parts of the medical journey that will always require a human in the loop. So, I don't see a situation where your smartphone tells you that you've got cancer and it's a terminal illness, or I don't see a situation where your smartwatch tells you you're going to go blind. At least not long as there's something primitive. There's a primitive requirement of humans for this to be done by other humans, I would say.
Thank you. We've got a few more questions. So, when do you expect the AI algorithm to be adopted in clinics, and what timelines are you thinking of?
So that, I would say, I would like our system to be being used in patients within the next 1 to 2 years. I don't think that this is 5 years away. Yeah.
I think I've got a question that's just come through. So I've been asked, did you personally sort of take any courses other than your sort of medical and clinical education to get involved with sort of the AI work that you were talking about? If you did, do you think it's a necessity? If not, do you think it's something that can be learned?
So I think, so the fact of the matter is that I don't have any computer science or engineering background. I'm not really involved too much on the coding side of things, yet I have somehow found myself leading a clinical AI research group with however many PhD students and however many medical students and junior doctors. And the reason for that, I think, is actually, it turns out that actually the computer science, the training of the model is only one component of a much broader spectrum. And in fact, identifying the novel application and aggregating and curating the data is often the much more difficult and time-consuming part of it. And then you train the model. If you've got the right data and the people know what they're doing, things move pretty quickly. And then you enter this other long phase on the other end, which is around the clinical validation, the regulatory approvals, and things like that. So I did something that a lot of people on listening might have done, which is I started doing some courses on Coursera, like machine learning and deep learning.ai and stuff like that. And the truth is, I haven't really had time to complete them. And they weren't really necessary. Like if I'm working with someone like Olaf Ronneberger from DeepMind, there's no way that there's any point in me being the one doing the coding. And now as I work increasingly with computer scientists and engineers from UCL and Cambridge and otherwise, we work together. So it's about me knowing what I need, knowing just enough to be able to work with them in a productive way. So we specifically made this short course, which is the first one that we're running, which is about sharing all that other knowledge that we've gained, or beginning to share that over the 5 years. There's plenty of courses that teach you how to code in Python. There's not that many that tell you about all the other stuff.
Thank you very much. You have a very, very insightful answer. Yeah, thank you. Yeah, so I think, yeah, I think that's all that we've got time for. So I will probably sort of move over to introducing Huw Jones, our next speaker, if that's okay. So we're very fortunate to have Huw as our second speaker. He's the founder and executive director of the Virtual Doctors. They are a leading telemedicine charity who go by the really inspiring motto of "What if a smartphone could save a life?" Their work has enabled healthcare provisions to individuals in low resource settings such as Malawi and rural Zambia. And in order to achieve this, sort of Huw and his excellent team, they've made use of a very innovative cloud-based telemedicine service to connect clinical officers in these remote locations to specialist clinicians based here in the UK. And so without further ado, I'll pass over to Huw to talk about how he founded sort of what is a really inspiring sort of social enterprise.
Thank you so much, Lohit. It's a pleasure to be here and share our work with you. I'll just go to share my screen. Find the I can find my presentation. There it is. So I hope you can see my presentation. Brilliant. So thanks again, Lohit. So my name's Huw Jones. I'm director and founder of the Virtual Doctors. So we are a telemedicine charity based in the UK. We're also registered in Zambia, and we currently provide free telemedicine services to over 230 health facilities, that's rural health centres and hospitals, right across Zambia, which is in sort of central southern Africa. And we've also have a long-standing pilot running in neighbouring Malawi. Before I go any further, I think just to sort of clarify, and this sort of comes on from Pearse's presentation of what actually telemedicine is, and this, because there's many different, there's e-health, digital health, but in this instance, and this is taken directly from the dictionary, the remote diagnosis and treatment of patients by means of telecommunications technology. And of course, there's a whole plethora of different types of medium to deliver telemedicine. You can use HF radio, the telephone, of course, and then of course there's the internet, and it's the internet that we use to deliver our service. And it's a very simple, easy to use bespoke app that we put on a smartphone. And it essentially allows a rural health worker, a clinical officer, when they're faced with a complex case they struggle to deal with, they're able to communicate the details of that case with a volunteer doctor, no matter where they may be, for diagnosis and treatment advice for their patients. My background is just over 30 years now working on and off in Africa. I went out there in the late 80s originally, and but most of the time I've spent there has been working and living and working in rural areas and building up some very strong and close relationships with the communities who live in those areas, but also witnessing many of the challenges they face, particularly around primary healthcare. And I suppose the genesis of the charity derives from those experiences. So I'd just like to start with a little story. Many years ago, I was driving in a very remote area of eastern Zambia. So you can see the map of the African continent there, and Zambia sits in the sort of southern African region. And as I drove down this very bumpy, dusty track, much like the one you can see in this photograph, I started to see drops of blood on the track as I went. And as I kept going, I saw more and more blood. Now, at the time, I was very close to a national park, and I presume perhaps maybe a lion or a leopard had killed an animal and then dragged it up the road. But as I came around this very sort of big bend in the track, I saw this man cycling his bicycle with his wife sort of sitting on the handlebars, sort of leaning against him for support. Now, it's a pretty common sight to see, people with bicycles and carrying passengers like that in a rural area in that region. But in this instance, the woman was in a very poor condition. She was heavily pregnant and the blood was coming from her. So I stopped, I helped them into the vehicle, and I drove as fast as I could to just try and find some sort of help. And as I drove, I asked the man, what had happened. And he told me he'd taken his wife to the health centre just outside the little village where they lived, but there were no doctors available to help them. Now, of course, she really needed emergency care. She needed secondary care. She needed a hospital, but there were no ambulances available. In fact, there was no motorised transport at all. And so that man took the only option available to him, and that was to try to cycle his wife to the nearest hospital. Now, the nearest hospital to where we were was about 60 miles away. It was a very, very long way. And it was in November when I picked them up. So November in that region is just before the rains come. So it sort of builds up and gets very, very hot and very, very humid. And she lost a huge amount of blood. And very unfortunately, as we drove, she just very quietly passed away in the back of my vehicle. And there was absolutely nothing I could do about it. Now, I have to say that there's not a lot that telemedicine could have done to save that woman's life. If she needed emergency care, she needed a blood transfusion. But there are certain events that can take place in our lives that act as a sort of a catalyst, I suppose, to make us want to do something. And that was the catalyst, for me at least. And so as the months and years went by, I related this story to friends of mine, but a lot of doctors I knew in Zambia and in Malawi, and of course in the UK. And the interesting thing was that they all expressed the very same desire. They all wanted to help, and for free. But the problem was none of them were in rural Zambia. And so the question became, well, how can we connect all these wonderful doctors offering their medical expertise for free to a rural health centre like that one that man had taken his wife to? And so around about 2007, we secured permission from the Ministry of Health in Zambia to carry out a pilot or a trial of telemedicine and various types of technology in a rural health centre about 60 kilometres south of the capital, Lusaka, Kafui district. And then we rapidly expanded that to 6 pilot sites. So we had these 6 sites running, and we tried all sorts of technology. And you can see here some photographs of some of the stuff we tried. So we had on the VSAT satellite for the provision of internet bandwidth. We had desktop computers to run the platform. We also tried netbooks a bit later on. And then we also used commercial telemedicine software. We ran this system trying different types of technology for several years, but there were issues with all of them. The VSAT satellite was very expensive and complicated to set up. And the bandwidth on a monthly basis was costing quite a lot of money. The desktop computers were often rendered redundant because there were a lot of power outages and power cuts in the region. And Zambia is heavily reliant on hydropower, and often when the water levels are low, if there's the mines, the industry needs it, there's often power cuts, so we'd lose the power to run them. And thirdly, the commercial telemedicine software was very complicated to use, quite clumpy, and it just wasn't really fit for purpose in a low resource setting like this. Now, at the same time, the mobile phone network, of course, was really kicking off in the region. The networks were going sort of deeper and deeper into rural areas, and with it, of course, went data, the internet data. So that was a real paradigm shift for us. It made us step right back to the drawing board, and we went back to the users. Now, I have to sort of sidestep here for a minute and say that the impetus for this service wasn't us going to them and saying, well, this is a really good idea, you should use this. The demand came from them. It came from the rural health workers, and in particular the clinical officers, who really wanted to be able to communicate with the doctor. If we can talk to a doctor, it'll really help us with our patient management. And 2 very important points came out of the study we did and the interviews we had with the clinical officers using our service. And we sort of said to them, what would help you make best use of this service? And they said, well, firstly, we want something that's very easy to use and very easy to learn to use. a tool that we can fit in very easily during the very busy patient consultation period of the day. And secondly, they suggested, why don't you just use smartphones? You know, many of us have them. They're very easy to use, intuitive, you know, pieces of kit to use, and you can buy them here. So we took that information in amongst many other things. And then we went to our volunteer doctors at the time, and we asked them, what is the sort of the bare minimum amount of information that you require as a doctor to formulate an opinion on diagnosis and then offer treatment advice? And that we took on board, and to sort of cut a long story short, that gave us the system we have now, which is a very easy to use, custom-built app, telemedicine app that sits on a smartphone that allows a clinical officer like Kennedy Malenga on the left here. Kennedy is in Ngwere Rural Health Centre in southern Zambia, to communicate with Dr. Simon Gazy. Simon's a GP partner, he's also a dermatology specialist just outside of Bradford, to diagnose and treatment advice for his patients. And we also provide a lot of educational. So we have this, the smartphones with the telemedicine app, but it's also the education component is very strong. We do a lot of targeted podcasts, case studies, we have forums, a lot of solidarity building and high quality e-learning resources, because the beneficiary for us is the clinical officer, someone like Kennedy. Because if we can improve his skills and knowledge to a point where he no longer needs us, particularly as a charity, that means that's job done. We as a charity, we should be looking, how can we put ourselves out of business and achieve our aims here? And that's what we set out to do. Now, the doctors we have about 190 volunteer doctors, GMC registered doctors in the UK, and we have about 5 HPCZ, which is the sort of equivalent of the GMC in Zambia, who also answer cases, because long term, our ultimate aim is to embed this in the Zambian health system, becomes theirs, with their doctors running it. But most of our doctors happen to be in the UK right now. And they cover about 25 different specialities of medicine. And you can see here some examples. So the top left was a toddler with severe burns. This was often people cook on the floors of their homes and houses. And this poor child got very badly burnt in a fire. 40% burns. The 7-year-old girl to the right there had HIV. The CD4 count was all over the place, and she had all the associated issues with HIV. She had a terrible skin rash all over her body. The photograph in the middle of the hands, that's a man with leprosy. And then on the top right, it looks rather gory. That's a young boy who was bitten on his ankle, just above his ankle, by a puff adder. The puff adder has a cytotoxic venom, and you can see the necrosis on going up the leg there, very painful indeed. And on the bottom left, this is an interesting case of what's called osteomyelitis, essentially an infection of the bone. It looks like there's a trauma on that boy, but it's actually coming from the inside. And he'd been walking around like that for a year. They'd been giving him antibiotics, unaware that this was an osteomyelitis. And a radiologist in the UK picked this up, and along with a consultant in Birmingham, identified it and said that he really needed to be operated on immediately, otherwise he'd lose his leg. And luckily, they were able to treat him locally in Lusaka. They all look quite severe, but these all have a positive outcome. So it just gives you an example of the diversity of cases, some of the severity of them, and also the life-changing nature of the support we can provide through remote diagnosis and treatments. So just as a breakdown here of the specialities, a good proportion of our volunteers are GPs, but they also double up, maybe like Simon as dermatologists. But you can see we get a lot of requests for dermatology, gynecology and sexual health, and pediatrics and obstetrics seem to be the most common presenting cases. And these are just examples of some of the health centres we support. Generally, they're very, very basic. They're built quite, the roofing sheets are often made from aluminium or asbestos. And there's very little sort of insulation underneath that. So it can be extremely challenging working in these health centres. It's hotter going inside than it is coming out with some of them. You can see on the bottom left there, that's a chap called Andrews Pirrie consulting, using our service with a doctor in the UK with all his patients. And then also there's sort of solidarity. We try to encourage other health workers, because the GMC equivalent in Zambia authorizes clinical officers to be able to communicate with the doctor. But the nurses, and on the right there, the one on the far right is a midwife, and the woman on the bottom there is a senior nurse. They'll often share their cases with a clinical officer who can consult for them and feed that information back. So share peer support there. And on the whole, you know, and this is a very basic breakdown of M&E, but, you know, it's very positive. The clinical officers are very happy with it. 90% they said it helped improve patient symptoms and they've used it. Prevents referrals to hospital, very important. And they find it very educational. So just to sort of sum up, you know, a lot of benefits and aims here, but I suppose the three core aims really are to help rural health workers treat more patients in their own communities. Secondly, it's to help prevent unnecessary referrals to secondary or hospital care. You know, why should, you know, a very unwell patient have to cycle or walk many miles, particularly when they're very unwell, when they can be treated in their community? And thirdly, and most importantly for us, it's to improve the skills of rural health workers in the region. And just finally, just to give you an idea of the extent of our service, we are currently in just over 200 health facilities. That's rural health centres mainly. And we also support in each district the main referral hospital, the district hospital. We are going to be expanding further in Zambia this year, and we're also in Malawi as well. And we've got major expansion for Malawi. So we're covering about 4 million population at the moment. And interestingly enough, we had a request from a primary care network to support our service locally for the NHS in the UK. So the last year, our volunteers, we rely on volunteers to manage our technology, have been re-engineering our service so that it meets data protection, impact assessment, and NHS standards. That's quite exciting for us. So that says November there, but that was pushed through with the current coronavirus that's been delayed because of the rollout of the vaccine. So hopefully this month we'll be implementing the service in the UK. So I've come to the end of my talk. I hope that was interesting, and thank you very much.
Thank you very much, Huw. Yes, yeah, it was really, really interesting to hear about the journey of the virtual doctors and how much of a positive impact it's made. We've got time for maybe a couple of questions. So as we did with Pearse, please feel free to email, just put a message on Zoom to either Rachel or myself if you do have any questions.
Yeah, so we have one question. So it's, how is the project being funded?
So we're a charity. So at the moment it's funded by 100% charitable donations, all from the UK. So trusts and foundations, individuals. I've spoken to nearly every Rotary Club, I think, in Sussex and Surrey, and even church groups. So that's how we fund ourselves at the moment.
Okay, so I've just got a question in, which was firstly saying thank you. So they've asked what the sort of the business model of the virtual doctors is to sort of ensure its sustainability and growth over time.
So in terms of sustainability on the ground in Zambia, as I said, we work very closely with the Ministry of Health. We have a mandate or a contract MOU with the Ministry of Health. So we are currently training their trainers. So we have Ministry of Health trainers. We train on how to train the clinical officers. They work very closely with the clinical officers and they monitor our service very closely. And we're gradually transitioning to an institutionalized service within the Directorate of Clinical Care is what our service comes under. And eventually we'll hand it over to them and step back and they will run it within the system themselves. We'll always support them with the technology support or doctors, but essentially they're going to mobilize their own doctors onto the service to answer their own cases. In terms of finance, that's more challenging, and we're trying to build ourselves up so we can approach more sort of statutory grants, like the DFID grants, for example. We're also hoping that if we can roll this out in the UK with the primary care network and their plans for it, that they will be able to budget for that. So that would be finance coming in 100% of net revenue within support our work in Zambia, Malawi, and beyond.
Right, okay. And I think we've got just about a couple of minutes just to do one final question, which is, are there any plans looking ahead in the future to sort of scale up to other countries that are sort of in need of this kind of virtual clinic provision in their lower resource areas?
Yes, certainly. We've had a lot of interest from other countries in the region. We've had some strong interest from Uganda, South Sudan, Somalia, and a number of countries in the African region, and also outside. We've also had some interest from, I mean, as far west as the Solomon Islands and West Papua. So, the potential is there. We're very small, and we rely heavily on volunteers. So it's just working within the capacity we can, but we certainly would love to do that one day, yes.
Brilliant. Okay, so thank you very much, Huw, for answering those questions.
You're welcome.
We're going to move on to sort of a networking session. So we're going to have some breakout rooms being put in place. Obviously, please feel free if you don't want to sort of participate. It's absolutely fine if you want to stay in the main room. Both Rachel and myself and some of the other MEDx team, medtech.
And the fundamental message has just been reinforced, which is our health system can't cope with the demand they're facing. It was true before the pandemic. It's true even more so during the pandemic. And it's a mixture of kind of the complexity of conditions that people suffer from and live with as the populations age, but also the fact that worldwide we're missing more than 7 million doctors and healthcare professionals to meet the demand. And this staggering figure of nearly 400 billion is what we would require if we wanted to provide universal healthcare around the globe. Granted, this year is probably, that figure has probably exploded. So this number is prior to the pandemic, was generated prior to the pandemic. But even if we look at kind of a specific disease or disease category, pneumonia is a specific passion of mine because I was at the WHO focusing on childhood pneumonia and what we can do to address the fact that for decades it has been the number one killer of under fives. It's a perfectly treatable condition. It doesn't make any sense why it should kill nearly 1 million children every year. But it's equally the same disease that causes a lot of avoidable hospitalizations for our elderly people. And a lot of this has a common denominator of diagnosis and treatment very often arrives too late. And sometimes it's a case of kind of the stories that Huw was telling in the previous presentation of rural settings, or just the access to healthcare being kind of impacted by the geography of where people are. But very often is this supply and demand challenge. Even in the UK at the moment, we face these challenges. So fundamentally, as a company, we kind of set out to build infrastructure and technology that would accelerate the access to diagnosis for people around the world. And it just so happens that I have background in AI, and I do believe that machine learning and advancements in that side of technology have a very important part to play. But as we learned in the first presentation, that's a very complex journey, and it needs to be designed and executed in a very careful way. So the purpose of my presentation is basically to give you some kind of practical stories from the field of developing and deploying machine learning driven solutions for improving access to healthcare in two very different geographies. So just as a brief summary, what our technology does and looks like is effectively a digital bridge between community settings and the existing healthcare infrastructure. So on one hand, we have a mobile application that's designed for non-medics. This could be carers, nurses, community healthcare workers. And it comes in combination with sensors. So things like pulse oximeters or digital stethoscopes, blood pressure cuffs, thermometers, etc., etc. All of those come in one kit that the carer knows how to operate via the mobile application. So everything is connected. They follow a very intuitive and picture-based process so that within 10 minutes, they can capture a full clinical profile or picture of the status of the patient that they have in front of them. And throughout this experience, they receive a lot of decision support. And later on, I'll give you a few very practical examples of this. By the end of the checkup, they are presented with a summary that stratifies risks and then gives them recommendations of what they should do next. So all of this is kind of the community side of this digital bridge. On the doctor side, which imagine, for example, being a GP practice, the GP can access a web portal where they can see a risk stratified list of patients, particularly if they're managing large communities. It's very difficult to know where to start when you have endless number of people that you have to attend to. So with the help of AI, we're able to stratify risks and then highlight the people that should be seen first. And then we present them with a full digital picture of what's happening to this patient in the context of their overall health. What are the things you should be worried about, and support them in making decisions so that remotely they can either prescribe treatment directly, or if there is something more complicated, escalate to other parts of the health system. So really then the rest of my talk will focus on highlighting the specific challenges that one should attend to when designing these types of solutions, because remote monitoring as a concept has been around for several decades now. People have been talking about capturing measurements or self-reporting symptoms and then sharing them with their doctor for a very long time. But there is a reason why it hasn't scaled. And the very painful reason is that if that data is not carefully refined and validated, it ends up overwhelming clinicians with information they don't have time to deal with. And that's kind of been our journey of really resolving these challenges in scalability across two settings. So the two settings I'm referring to are our work in urban slums in Mumbai, India, and also care homes throughout the UK. And I'll give you a bit of a snapshot kind of overview of both of those. So our work in India really revolves around equipping community healthcare workers, not too dissimilar to kind of the type of workforce that Huw was talking about, but these specific workers are based in urban slums with the tools to be able to identify dangerous childhood diseases such as pneumonia early on. So we provide them with a kit. You can see some of the sensors here. So this is the digital stethoscope and the pulse oximeter, as well as the mobile application. And they go around the urban slum area they're responsible for, conducting checkups about 10 minutes each, capturing this information and then identifying who needs to be escalated to a primary care clinic that we've then equipped with our doctor technology to be able to provide either remote consultations or have the child be kind of taken to the clinic if something needs to be done locally. The impact that we've seen running these types of programs for over 12 months is the acceleration of the diagnostic pathway, particularly for the very severe conditions. In a country like India, where a lot of the healthcare is actually paid for out of pocket, this is tremendously important both for the family as well as the health system. So some of the numbers that you're seeing here illustrate the reduction that we've seen in the cost to the health system as well as the family. And the latter is very, very important. So for example, in the kind of communities where we've worked, we've seen more than 10% of monthly income savings for that family if this type of health intervention is introduced in the slum. And the other setting, very different to the child setting that I'm describing, is focused on elderly health. So this one was kind of conducted, or it continues to be conducted with partners across the NHS. So we work with care and nursing homes in East London, as well as their corresponding GP practices, as well as the clinical commissioning group in the area, to really redesign the care pathways, particularly during the pandemic, digitize them, and also kind of restructure the focus such that a lot of the issues can be identified early on and hospitalizations can be prevented. And again, just giving you a flavor of some of the impact that we've seen. So one of the really important changes we've seen over the last 8 months is really changing the type of care from reactive to proactive. So prior to the intervention, people are used to seeking help when someone was really, really ill. Now we've converted this into a model of regular monitoring and identification of issues early, so that we can avoid complications effectively. And the other impact that we've seen is through this being able to reduce the reliance on GPs. So then giving you a bit of an idea of what the role of AI in all of this is. So we design algorithms that effectively break out into different levels. So level 1 is really about this data refinery. So all these sensors that I'm talking about and the self-reported symptoms can be incredibly noisy. And if that's just passed on to a clinician, they will be overwhelmed. Too many patients, too many data points, they will know what to do with it. So level 1 is really focused on refining this data. Level 2 then makes sense of the data once refined and says that here there is a high risk of X and here there is a high risk of Y. And again, I'll give you a couple of examples now. So sticking with level 1, the refinery of data, respiratory rate, which for anyone medical here would know is a very manual process of watching the chest moving up and down, is incredibly prone to error, even in hospital settings, but even more so in community settings. So the graph you're seeing here is a snapshot of some of our community users where they tend to favor the number 18 and 20. There are all sorts of logical reasons for why this happened, but this is not a true representation of obviously all the patient groups. An example from the community healthcare workers in India as well indicates the same. I'm not going to go into the numbers, but effectively what we are able to do algorithmically is automate the derivation of respiratory rate from sensors like pulse oximetry and the stethoscope, so that we both save them time, but also improve the accuracy of the count. And I can give you more kind of details on this if you're interested later on. The other thing that we're able to do is, in the context of proactive monitoring, is digest these very large volumes of data. So this is an example of one of our elderly patients that's being monitored over time. This is his blood pressure, this is his heart rate. Quite honestly, no GP has time to be going through individual measurements on a regular basis for the thousands of patients they're responsible for. So on this occasion, for example, the GP missed the fact that this person was deteriorating and had a fall. However, algorithmically, we're able to pick this up and we can alert them and say, you should focus on this person because a fall is coming. And again, happy to do a deep dive. Then the third category I just wanted to highlight is going a step further, and it kind of goes back to the first presentation, and really decision supporting diagnosis. So this is an example of clinicians diagnosing childhood pneumonia, where if we solely rely on clinical guidelines, we would be incredibly sensitive. So we'll pick up a lot of people, but we also falsely diagnose many that are actually not sick with pneumonia. Equally, if clinicians, these are GPs, do not have decision support and are solely making a diagnostic decision just based on one examination, they can be very specific, meaning they will, if there is a pneumonia case, sorry, the other way around, they'll be very specific, but not very sensitive, meaning it might take a couple of consultations to actually reach a diagnosis. And this middle group here is when we start introducing different levels of decision support. So the dark blue dots are clinicians with decision support for interpreting digital sounds from a stethoscope. And you can see that basically improves their sensitivity. So they're able to pick up more and more cases. And then the final one is if we decision support on multiple fronts. So combining everything with the respiratory rate algorithms that I mentioned, with the lung sounds automations, and also suggesting which patients need more attention, kind of gives us the best of both worlds. This is by no means to say that clinicians are not necessary in this pathway. Absolutely not the case. It's simply illustrating how we need to be very careful in identifying what are the most uncertain steps of a diagnostic process and introducing the right decision support tools so that we help clinicians to make the best decisions possible. And that's it. I know it was a very kind of quick run through, but I just wanted to give you a quick overview so that if people have questions, I can focus on very specific elements.
Thank you very much, Elina. And if it's okay, we can sort of move to the question and answers, if that's okay. So as we have for the past other two speakers, please feel free to just sort of drop the questions in the chat, and then hopefully we can ask you. But yeah, thank you so much for delivering that talk. Really interesting to see how it fit into the sort of other talks that we had today and sort of the running themes that have been for sort of our fourth MEDx event. So thank you very much. So I've got a question in, if that's okay. Yeah, so the question is, so from your numerous experiences, sort of what similarities and differences have you discovered between sort of founding a startup as an entrepreneur as opposed to sort of conducting research within sort of an established organization? Sort of, do you mind sort of commenting on the difference between those two?
That's a really interesting question. I think Dr. Keane probably answered that question indirectly in his first presentation. I would say they just have very different flavors of motivation for me. So working within a research organization, be it an academic organization or a public health organization, is intellectually fascinating, and you get to really unpick the nitty-gritties of a problem. And really challenge yourself in imagining ways of approaching that problem. Doing that in practice, so practically delivering solutions, is a very different experience. It comes with a lot of compromises. So a lot of the fancy technology that you can develop in an academic environment doesn't work in practical environments. So to give you a flavor, we have to run all our algorithms on a mobile phone. That's very, very cheap. So that comes with compromises of, can we run the fanciest deep learning algorithm in that environment, or do we need to develop something that balances accuracy with the limitations of the environments that we serve? So it very much depends, I guess, personally. Are you looking to solve a problem, or are you looking to advance science and humans' understanding of where the bounds of science lie, I guess?
Okay, thank you very much.
Yeah, so we've got another question come in. So you mentioned that it was your work in with the World Health Organization that sparked your passion. Would you be able to comment more on how you devise ethical solutions to provide early diagnosis?
Yeah, so I guess there are two separate questions. So my work with the WHO was effectively looking at one of the biggest, in my opinion, crises in public health. Why is childhood pneumonia still the #1 killer of under 5s? And I was looking at opportunities to effectively address this challenge, kind of constantly going around in circles, coming to the same point, which is we don't have enough doctors, and yet the diagnostic process is so complex. There isn't still one sensor or one measurement you can perform that would automatically diagnose the disease, and hence we can't really accelerate the diagnostic process with the tools we have in hand. Personally, I then and did a PhD on this, designing these specific solutions in an academic setting, and that's kind of how I landed where I am today. But I guess on the second point of how you go about designing ethical solutions for these problems, I think the key for this is really collecting multidisciplinary perspectives, because these problems are entrenched for a reason, because they're so complex and they're driven by so many factors, often not just medical or clinical. There are societal contributors. There's technological barriers, etc., etc. So if one wants to really get to the bottom of solving a problem of that scale, you need to collaborate with people that kind of bring these different perspectives, but also stay true to what you set out to do. And for me, it's a little bit challenging doing that in an environment that's kind of single-handedly focused on, let's say, the accuracy of the algorithm, or single-handedly focused on just the clinical implications of it. Some of these problems just require very multidisciplinary teams, and we've heard from the first presentation that they can be built through different organizations, or they can be built in-house.
Thank you very much. We have just one more question that's come in. So they've asked, would you be able to sort of accelerate the sort of type of work you're doing and the diagnostic process for diseases like cancer?
So we are currently mostly focusing on respiratory conditions, although more and more diversifying by virtue of the elderly populations we're working with. Cancer is a little bit more challenging because imaging plays a very big part in this. And there are other companies, Chiron Medical being one that I would highlight. They're doing some tremendous innovation in this space, accelerating the diagnostic pathway from an imaging perspective. Does the type of solution that we're developing have a role to play in the even earlier detection? Absolutely. So for us, the logical one to look at is lung cancer first, before thinking about diversifying in other categories. But this is where I would highlight collaborations will be 100% key, because there is no one group, company, organization that will be able to cover the whole spectrum of solutions we need to develop, and we need to eventually start thinking on a system level, how do these things talk to each other and coordinate.
Thank you very much.
Right, so thank you very much, Elina.